So I don't know if you all were there for the that session, that I did before on chest pain. So do you want me to start from the beginning or from where we stopped last time? I'll start from the beginning then. Just chest pain. Okay. Okay. So in chest pain, I'll just give you the way we're going to do this is I'll just tell the history, examination, what are the investigations you're going to do, management, and the possible questions that you can get in your long case. Okay. If I'm going too fast, just tell me to slow down and I'll slow down. Okay. So when it comes to chest pain, most of the time your long case will be it will be some ACS. ACS will be most likely the long case. It can be something else, but we'll mainly focus on ACS. Okay. So because today's topic is ischemic heart disease, now. So when it comes to chest pain, and you're going to the ischemic heart disease chest pain history, but initially what you will have to do is to take the introduction and all the normal basic details, and then you tell the presenting complaint. So you will say, my patient is Mr. Pereira, a 52-year-old but carpenter from Kotehena, is presenting with a father of two, is presenting with central chest pain for 2 hours duration or something like that. Okay, so you say a very small presenting complaint, and then you go to the history of presenting complaint. So in the history of presenting complaint, what you're going to do is initially you're going to talk about pain evaluation. That is, how are you going to talk about the pain evaluation? In that, you're going to talk about this Socrates. So when it comes to Socrates, we know it's a site, onset, character, radiation, associated factors or aggravating factors, then timing, exacerbating factors, and severity. So initially it's symptom evaluation, then we're going to go to risk factors and etiologies, and then complications, and what has been done so far is what you will talk in your history. So initially when we're talking about the pain, so what you will say is that in a history, this patient who was apparently well, apparently in his normal health till 1 day ago or 2 days ago, when he developed acute onset chest pain. So there you have produce the onset, or you can say acute onset retrosternal chest pain. So you finish the site and the onset, then which was constricting in nature, and it radiated to the neck, left arm, and jaw. Okay, so then you have finished the radiation. It was associated with autonomic symptoms such as sweating, nausea, and dizziness and palpitations, something like that. Or it was associated with autonomic symptoms such as sweating and nausea, but he did not complain of vomiting or palpitations or dizziness. Then you can say it lasted for about 1 hour and did not relieve with rest. Okay, or it lasted for whatever and relieve with rest, or relieve with sublingual GTN, or you can say it did not relieve with rest or sublingual GTN, and it was made worse on exertion, and he complained that it was of very severe quality. It was very severe in nature, and the severity remained the same until his hospital admission. Okay, it's good to say for how long the severity remained. Was it in the same intensity, or whether the severity reduced, or whether the severity increased. Okay, and then you have to say that after how long did he come to the hospital. Okay, that is also something. So when you're asking the history, ask there when was the pain onset, at what time he got the pain, and after how long did he come to the hospital after the onset of pain, because your management will depend on the time that he comes to the hospital after the symptom onset. Okay, so that is your pain evaluation. Then without going to complications right away, then you have to, so this is what we did all this time, you have to talk about the other causes of chest pain. Okay, so you rule out your differential diagnosis. Even though you know that this is most likely going to be a MI, you have to ask some questions to rule out other differential diagnoses as well. uh, Sorry. So in that you will say initially it's your ACS. So that when you have asked all of this: central location, constricting nature, radiation to neck, jaw, upper limbs. It can be to the left or right, okay, but usually it's on to the left side. And then you saw these autonomic symptoms: nausea, vomiting, sweating. Those are all the questions you ask for ACS. Okay, then the next differential diagnosis is aortic dissection. So that would be other things that you need to say. So now this causes instantaneous onset of pain. So that will be different from the onset that you are describing, right? It's not very acute, and it's kind of like a gradual onset, but not a sudden onset. Okay, don't say it's a sudden onset pain, because ACS is not sudden. Then so this causes this is aortic dissection, and it just radiates through the back. So when you're saying your ACS also, this is a when you if you aortic dissection history would be like he complains of what sudden onset chest pain or instantaneous onset chest pain, which is very severe in character, and it radiated through the back. Okay, that's the way you will present that. And the main other way that you will find the differences in your examination, where you have to check both pulses and you have to check blood pressure on both hands. Okay, so remember when you get an MI case to do this, to check pulses on both hands and to check the blood pressure on both hands. Because if you have unequal pulses or asymmetric blood pressure, that is more than 20 millimeter mercury difference in both arms, then you can say that it is likely that this can be an aortic dissection. And if it is proximal to the aorta, if the aortic dissection is proximal to your aorta, in the proximal part of the aorta, then you can have the aortic valve also getting involved, and they can develop aortic regurgitation. So that you will also hear in your examination. Okay, so that is two things. Then your third one will be pulmonary embolism. You are the DD, and usually chest pain occurs with small emboli, and because large emboli will go and block the entire blood vessels, and also when it blocks that, there will be sudden, you'll have this syncope and pre-syncope rather than chest pain. So it is a small emboli that causes chest pain, and it's usually a pleuritic type chest pain. So you need to ask if there is breathing when you in the inspiration, if there is chest pain. So yeah, and then just say that whether the patient developed any hemoptysis and shortness of breath as well. So then you can ask if you are suspecting that this is pulmonary embolism, or you may think that your differential diagnosis pulmonary embolism is high up there. You can ask for these risk factors, but if it is not, don't spend time on these things, okay? Because your main focus is to describe a very good ACS. If you know that the condition is ACS, you can give short other answers without asking in detail about these things. Okay. So pneumothorax is another one where you have acute onset chest pain with worsening shortness of breath. They can have it's acute in onset, and it's more in young people who have tall young people. If it comes to a male, then they can, or if it's primary pneumothorax, secondary pneumothorax means if they have any underlying respiratory conditions. Then pneumonia can be another cause. Okay, so you can ask about pneumonia symptoms. So for this, you will just ask if there is fever, if he has a history of fever, cough, or shortness of breath, should be enough. Then you can also ask about pericarditis. That is the only thing I would ask here is if he has chest pain that is relieved on bending forward, because anyway you will ask all of these other things there, and you will cover everything else. So then you just ask if that chest pain is relieved on bending forward or not, to just rule out your pericarditis. Okay, and then ask about this. Now this is a very good thing to always ask, because this is very common. Okay, gastroesophageal reflux is very common, and they come with chest pain because of this. So ask about epigastric pain, dyspepsia, and abdominal distension also. So in your one sentence, you can finish everything. After you have finished the main complaint of the history, and you have finished the presenting complaint, then you will say, so this the pain does not, you will just go according to this order. The pain does not radiate through the back, it's not relieved on bending forward, and it's not pleuritic in nature. Okay, he did not develop any fever or any cough or sputum cough that is associated with sputum production, and also he does not have pain of he also does not have any epigastric pain, dyspepsia, or abdominal distension. That is enough. Okay, so then you have finished your DD in that sentence itself. So then after you have finished your pain with your Socrates, then you have finished your DD, then we are going to ask about some of the risk factors. Okay, now before going, I think the risk factors, before that you have to ask these things this to support your diagnosis of ACS. So in your history, you're going to talk about Socrates. So that is the pain, first part. Then the second part, you're going to ask ask about the differential diagnosis. In the differential diagnosis, talk about what you will say is this pain does not radiate right through the back. It is not relieved on bending forward. There was no associated fevers, cough, or sputum production, and sorry, and it is the pain was not pleuritic in nature, and also there was no associated dyspeptic symptoms such as regurgitation or what abdominal fullness or something like that. Okay, then you're done with that. Then the third part is now your diagnosis is ACS. Now you're going with the diagnosis of ACS. So now with this diagnosis of ACS, you need to give evidence to say that this is a ACS. Now how are you going to give evidence of ACS? That you have to say that there any other manifestations of atherosclerosis. Okay, so for that you can ask about stable angina. So how will you ask about stable angina? Whether he has a history of chest pain on exertion, and whether that chest pain comes at equal intervals when he starts walking, and whether it's relieved by rest. Okay, so that is, you will ask for stable angina. Postprandial angina, any chest pain after having a heavy meal. Okay, then if he complains of chest pain after a meal. Then mesenteric angina, abdominal pain after a heavy meal. That is usually about 1 to 2 hours after having a heavy meal, he gets an abdominal pain. That will be mesenteric angina. Then peripheral vascular disease, you know how to ask that. You can ask those 5 questions, and mainly you can ask about intermittent claudication. Then TIA and stroke also, you can ask if there's a history of TIA and stroke. That is, you will ask if there's a history of sudden onset weakness of the limbs. Okay, you obviously, stroke is not just weakness of the limbs, but just to ask that in your history of chest pain will be enough. Okay, so you can just say this patient gave a history of chest pain on exertion, which was relieved by rest and sublingual nitrogen, sublingual GTN, sorry. And he also complains of chest pain after having a heavy meal. However, he did not complain of abdominal pain about after a heavy meal. He has, at this point, I think you can say intermittent claudication, because you're not going to describe PVD in detail. This patient complains of a history of intermittent claudication on both calves. However, he does not give a history of sudden onset weakness of the limbs. Okay, so then you have finished these manifestations, and then you're going to ask about the serious risk factors. Now, this cardiovascular risk factors, modifiable, non-modifiable, you already know this. Non-modifiable are your age, sex, then any genetics and all of that, family history are non-modifiable. Modifiable is your other risk factors, smoking, then your what you eat, what your diet, then alcohol and all of that will be here. Now, this thing you can ask in the history of presenting complaint, but I usually don't. I keep it for the social history and all of that in those components to ask there itself, so that you can fill those parts. Okay, so you don't need to ask it here. It's up to you where you want to put this. And then at the end of your history of presenting complaint, you have to say, then this patient was brought to the hospital about 2 hours after the onset of chest pain, and following admission, he was initially admitted to the PCU and he was admitted to the ETU, and he underwent an ECG, and whether he had any before you talk about that, talk about the complications. Okay, I missed that. Once you have finished this part, the supporting the diagnosis and risk factors, then you go here to the complications. Because I usually like to go in that order, where you talk about analysis of the symptom analysis, then your etiology, and risk factors, and whatever that's your DDs, and then your complications, and finally what has been done so far. So when it comes to the complications, what you can ask are these things. Wait, I'll show you a table. Yeah. So these are the complications of MI, and how will you ask this? So for, you know that arrhythmias can be a complication. So for that, you ask if the patient has any palpitations, and whether he has got any syncope or pre-syncope, because we know that sometimes bradycardias or bradyarrhythmias can cause syncope. Okay, so this is what you will say, ask in the history. Obviously, in the examination, you will look for these things. Then if there is any heart failure component. So in the heart failure, you're going to ask about shortness of breath, orthopnea, if there's paroxysmal nocturnal dyspnea, if there is dizziness, then the patient can also develop acute pericarditis. So for that, you will ask we already asked that in the main history as well. So you don't need to repeat it here. Or you can say he had no the chest pain, the progression of the chest pain. You can maybe explain that it does not relieve with unbending power, but always you don't need to ask this. Okay, so the other things are these, which you can't really ask much on your history. So the main thing to ask for complications are the patient did not complain of any following his episode of chest pain. The patient did not complain of any palpitation or episodes of syncope or pre-syncope. However, he did complain of having shortness of breath on exertion, which also associated with shortness of breath on lying supine, and he required about 2 pillows to lie comfortably without having any difficulty in breathing. And he also complained of having to wake up in the middle of the night with difficulty on breathing, and had to take rest about 10 minutes or something before he could go to sleep again, which means you're explaining both orthopnea and paroxysmal nocturnal dyspnea. Now, some people like it if you don't tell these words rather that you explain it in the patient's words, right? So better not to use orthopnea, paroxysmal nocturnal dyspnea in your history of presenting complaint. Some people are okay with it, some people are not. So better to stay that way. Okay, no. So then you have gone with your complications, and after you have finished the complications, so you have asked about palpitations, you have asked about what syncope, then you ask about shortness of breath, orthopnea, and paroxysmal nocturnal dyspnea. Just ask those 5 questions for your complications. It's enough. Then you're going to go and ask, so this patient, following his onset of chest pain, he was admitted about 2 hours after that to the ETU, and there he underwent an ECG, and whether he underwent any other investigations, whether troponin was taken, all of that. You can just say whether any blood investigations were done, whether an echocardiogram was done, whether you can do a point of care ultrasound scan at that point to check for heart failure, so whether that was done. So those things are some things you can do what was done at that time. And then you go and you say he was then whether he was sent for he was given the option of primary PCI, whether that was given as an option to him. Usually if they get primary PCI, they are sent to the cardiology ward, but sometimes you don't know, maybe they might bring a patient from there and so ask whether he had PCI. Then you ask whether if not whether they took consent to give any other thrombolysis. So that was whether consent was taken to give that. So you ask whether that was given, and then you have to ask whether he has given then when was he transferred from the ETU to the ward, and in the ward what was the management done in the ward. So in the ward, did they give any subcutaneous injections, because you want to know whether he has taken enoxaparin, right? And in enoxaparin, how many doses of enoxaparin has he taken so far? So if he has taken this, because we know that depending on the condition, if it is a STEMI, we have 10 doses. If it's non-STEMI, you have 6 doses, and ultrasound, if it's unstable angina, you have 4 doses, right? So that will depend on, and it will tell you BD now. So you're giving 1 dose in the morning and 1 dose in the evening. So then if it is a STEMI, it's 5, the patient has to stay for 5 days. Non-STEMI means 3 days. Unstable angina means 2 days. So even with the duration of hospital stay, you can get an idea about what this condition might be. Okay. Because remember, in the history, otherwise, with just based on the symptoms, you are not usually supposed to know whether this is a MI or an unstable angina. It is purely through investigations that you can find out. Although some people say that you can figure out what is unstable angina rather than MI based on clinical features, most of the books say that is not very reliable, and it is you have to use your investigations to find out what exactly the diagnosis is. But based on the management, you can get a clue. Don't go with that as your say that because this was the management, this is the condition. Just you can get a clue about what it might be. Okay. Yeah, because sometimes in the exam they can ask you based on the management what do you think is, because I remember in my PED mid appointment long case also, they asked, just because there was nothing to suggest that the patient had dengue hemorrhagic fever, but only thing that the patient was managed in the HDU. So then they asked, so what do you think this condition is? Do you think this is HDU, it is dengue hemorrhagic fever or dengue fever? And I said, because it was managed in the HDU, it's most likely dengue hemorrhagic fever, and that's what they were expecting. Okay, so just have an idea about it, but don't go with that as your main reason for your diagnosis. diagnosis. So yeah, so you have to ask all of those things at that point, and then you have to say whether after doing the main management, whether a 2D echo was done. Okay, because that was also important. You have to do a 2D echo before discharge, so whether that was done, whether any new medications were started for the patient. Okay, any oral medications that the patient was put on. After that, you have to say that currently how the patient is. The patient is currently doing well with no and does not complain of any chest pain, something like that, and he is able to ambulate in this normal health, something like that. You finish it off with how he is doing now. Okay, so that is the main history of presenting complaints. So now when you're done with the history of presenting complaint, it's the same thing as the others. So now others are, you ask for the past medical history, like, family history. You ask about something of this cardiac death. Early cardiac death is something you need to ask, and that is, these are the age cutoffs. So male means less than 55 years if they die, and females less than 65 years. Okay, then ask about this drug history, social history. In this social history, you can ask about the cardiovascular risk factors. Okay, so this is the main thing, is your history of presenting complaint. So just to recap on history of presenting complaint, go with the first we'll go with history of presenting complaint. After finishing with the presenting complaint, first ask about the pain. Use Socrates to ask about the pain. Second one is exclude other etiologies. So in other etiologies, you will say that this pain did not radiate directly through the back. It was not pleuritic in nature, neither did it relieve on bending forward, and there was no associated shortness of breath or fever with cough and sputum production, and the patient did not complain of any epigastric pain, dyspepsia, or abdominal distension. Okay, so you're done there. So your Socrates is done, your etiologies are done. Then you have to say this. What are the other manifestations? He complained of a history of chest pain on exertion, which was relieved on rest and sublingual but GTN. He also complained of a chest pain after a heavy meal, but did not complain of any abdominal pain about 1 hour after a heavy meal. He has intermittent claudication on bilateral calves. However, he did not give a history of sudden onset weakness of the limbs. Okay. Then you have done with this part. Then you have to talk about the complications. So he did not, the patient, following the onset of chest pain, the patient did not develop palpitations or episodes of syncope or pre-syncope, dizziness, but however he did complain of a shortness of breath on exertion, which is worse on lying supine and requires about 2 pillows to lie comfortably or to lie on the side to not experience any shortness of breath. And he also complains of having to wake up in the middle of the night due to shortness of breath, which is only relieved following period of rest of about 10 minutes, something like that. Okay, then you're done with the complications. Then you will tell, following the onset of chest pain, 2 hours after the onset of chest pain, the patient presented to the hospital where he was admitted to the ETU, and there an ECG was done, blood investigations were done, following which he was given an option to undergo primary PCU, but whatever, and however he declined consent, whatever, and he was treated with an IV medication which the patient is not aware of. Following this, he was started on subcutaneous injections, which was given around the umbilicus. However, the patient is not aware of the medication. However, my inferences, this is most likely subcutaneous enoxaparin. So the patient was given 2 doses of 1 dose at the ETU and then transferred to the ward. Following transfer to the ward, the patient received further 5 doses or whatever, and patient is now awaiting 2D echocardiogram, and has been said that he could be discharged. The patient also was further started on other oral medications and was educated about his condition thus far. Currently the patient does not complain of any chest pain, and he also does not complain of any shortness of breath, and he is in his usual health, something like that. Then you're done. Okay, that is your history of presenting complaint. Is there anything you want to ask in the history?
Machan, can you please tell again the duration of doses of enoxaparin?
Yeah. So if it is STEMI, you have to give 10 doses. Okay, so it is, what is the dose for enoxaparin is 1 milligram per kilogram. I'll just tell this. Now, when you have enoxaparin, you can give prophylactic enoxaparin and you can give therapeutic enoxaparin. Now, prophylactic enoxaparin is not relevant to this case at all, but I'm just telling you that the dose is 0.5 milligram per kilogram. Okay, but therapeutic enoxaparin, the dose is 1 milligram per kilogram. So if it's a 60 kilogram person, the dose is 60 milligrams. So here we are only going to give therapeutic enoxaparin. Always chest pain, this MIs and all of this, ACS, you're going to give therapeutic enoxaparin. So the dose is 1 milligram per kilogram. So how are you going to give that is you give 10 doses, right? So for STEMI, it is 10 doses and you have to give it BD. So you give one in the morning, one in the night. So the BD doses are 1 milligram. If there is no, that is, if there is no renal impairment, okay, if there's renal impairment, you have to reduce the dose. But if there's no renal impairment, you can give 1 milligram per kilogram. So STEMI is 10 doses BD. Then non-STEMI is 6 doses BD and unstable angina is 4 doses BD. So you're just dividing the number of doses by 2 to see how many days they'll be there in the hospital. So STEMI is 5 days because it's 10 doses. Non-STEMI is 3 days because it's 6 doses. And unstable angina is 2 days because it's 4 doses. Yeah,
Naveen, the 1 milligram per kg per day or for per dose?
for a dose.
Per dose. Okay, thank you.
Yeah, even though I said not the prophylactically we don't give enoxaparin, but that dose is still used when we give tenecteplase. Okay, because IV tenecteplase, I'll tell that in the management, when you're giving tenecteplase, before giving tenecteplase, we are giving enoxaparin now. So that dose is the half dose where we give. I'll tell that below also, just so that you understand. This part you understood now?
Much. Yeah, thank you very much.
Okay. Mm. Then moving on to the examination. So in the examination, I'm mainly just look at the general examination, look for pallor, Okay, now there is another thing that you need to see is that these patients sometimes when you take the history, they might not have anything. In my long case, the patient did not have any other risk factors. In terms of diseases, but he had smoking, a very bad smoking history. But other things were not there. So when you're taking the history and you don't find any other comorbidities, before you miss it, just check whether he is pale or not, because it can be some other, it can be the anemia that contributed to the minor. You don't know. So then just take a quick look whether he is pale or not, so that you can find whether that's a risk factor. Then check for this peripheral stigmata of hypercholesterolemia and thalassemata and all of that you can see. Then check for nicotine stains, check ankle edema because that might be associated with this what if there is any heart failure component. Look for heart failure, measure the blood pressure, like I said, measure blood pressure on both arms, and also check for pulses on both wrists. Okay. Mm. Then this is your checking if there is anything to do with if there is a heart failure component, right heart failure, and yeah, nervous system. If you can do it. If you can't, just say something. Then other things, I think this time in the exam, apparently there were people who helped to check the blood pressure and all of that. So I didn't know that. So maybe you can get somebody's help to check the blood pressure and all of that before, and check the BMI. Okay, that's another thing you need to do. I think in the exam this time they wrote the height and the weight on the side, and apparently there was someone with a calculator who was calculating the BMI. So make sure you use those helps that are there in the exam. Okay. So then this, wait 1 minute.
Naveen,
Yeah.
in this STEMI,
Hmm.
in thrombolysis,
Hello?
you said after thrombolysis we have to give this enoxaparin.
You have to give before and after, no? Yeah.
Before, what's the dose?
Before is half dose. So you give
After.
0.5. As I said. Yeah. After
Okay.
is 1 milligram per kilogram. Before is 0.5. So usually they give IV 30 milligrams before and then they give 60 milligrams after.
Oh,
Mm.
thank you.
Mm. Give me a few minutes. I'm trying to open something. Okay. Then we'll go to the first part of ischemic heart disease. We'll just talk about stable angina. Okay. Because sometimes they have given stable angina also as a case in certain places. Remember, stable angina is mainly a clinical diagnosis. But what they can have when it comes to stable angina is you have to do certain investigations. Okay. To say that there is some ischemic component to this patient's pain. So usually remember that in the stable angina, the resting ECG is normal, and troponin I is negative, and echo is also usually normal in these patients. So what you do is initially there is this step thing that you do, and you find out whether based on the clinical history, based on all of these investigations that you've done so far, you say what is the likelihood of this patient having a coronary artery disease. Okay, and then you grade that clinical likelihood. You say whether this is less likely or more likely. So if the patient is very likely that the patient has this thing, coronary artery disease, then we do something called invasive angiography. Okay, so invasive angiography means we are doing it, it's a very invasive procedure, and it's within the, you're going through the vessels and you're checking through the heart, and you're seeing whether this is whether there is any ischemic component, if there's any block in the heart. But that's just to put it very very simply. So it's invasive and all of that because it's through the radial artery, right? You're giving it through an artery. That is why it's considered as invasive. Although everything is invasive, this you say it as invasive angiography because it's you're going through an artery. So you inject the dye via the radial artery. And when are you going to do this investigation? That you will do it when there is in chronic CCS, that is in stable angina. Okay, and those indications will be when the patient has severe symptoms and when he is not responding to medication, and also when there's a very high cardiovascular risk. Now this cardiovascular risk is what I said, do all of these tests and see, and then when the patient has a very high risk, then you do this. Okay. So when you do this, when you detect if there is any obstructions, if there's any narrowing of the coronary arteries, then you will decide whether the patient has to do stent or bypass. So usually it's a therapeutic procedure then and there itself, where they will decide to do stenting if there are less than triple vessel diseases there. If there's triple vessel disease or more, then they would go for a coronary bypass surgery. Okay. Then this is let's say now you have this is very high, this is a very high likelihood. Now when you have another likelihood is when they have low likelihood, or when there is, let's say, middle likelihood. When there is very low likelihood, you don't need to do any other testing, no ischemic testing to do. But if there's a middle likelihood, okay, then you will have to test for ischemia. So this test for ischemia is where you have to do certain dynamic tests. So what are these dynamic tests that you can do? So the dynamic tests that you can do are, one is you can do an exercise ECG, you can do a stress echo, that is what they call is a dobutamine stress echo, and they prefer to do the dobutamine stress echo where you give certain dobutamine and check for the echocardiogram, is if the ejection fraction is low. Okay, if the ejection fraction is very low, then they would, without doing any exercise ECG, you would prefer to do a stress echo. Then you can do a myocardial perfusion scan, which is the most preferred option. That is this, that you can see this picture here, but it's not, it is available in Sri Lanka, but not very widely available. And then you can do a cardiac MRI also. So these are the dynamic tests that you will do for a person who has a middle likelihood of having a coronary artery disease. Okay. So we saw what you have to do with there's a very high likelihood, if there's a middle likelihood based on the history and examination, and if there's a very low likelihood, no need to do anything. But let's say there's a low likelihood, okay, the patient is young and has no risk factors, but he has certain symptoms of stable angina. Then you do something called a CT coronary angiogram. Okay, so this CT coronary angiogram is basically you inject it through the veins. So that is why it's not considered a very invasive thing. Okay, it's basically you inject the dye to the veins and you see what is happening here, right? You see whether there are plaques. So basically what they do is they calculate something called the Agatston score, basically to see if there is any coronary calcification in the arteries or not. Coronary vessels are their calcifications. So this test, this coronary CT angiogram, is basically, it says that it has a very good negative predictive value. which means that if it is negative, if let's say there is no calcifications, you have not detected any problems, that means you can say that this patient does not have coronary artery disease. Okay, you can exclude it. Okay, that's what negative predictive value means. You can exclude that this person does not have it. But if it is positive, then that does not mean that the patient has a very severe disease. Okay, so it's not a very good positive predictive value, but it's a very good negative predictive value. Okay, so that is what you have this CT angiogram. So just a little bit about this exercise ECG. What you should know here is that it's positive if there is a horizontal depression, ST depression. You're looking at the ST waves now, so if there's horizontal ST depression and if there's downsloping ST depression. So these two will only tell you that this patient has a typical ischemia. If this means equivocal, so it's about ATP. It's not typical, but these two will basically tell you that exercise ECG is positive. The exercise ECG is, these are certain just MCQ points. It's difficult to interpret in those who are having pre-existing ECG abnormalities like left bundle branch block, any pre-excitation syndrome, that is your Wolff-Parkinson-White syndrome, or severe left ventricular hypertension. These are hypertrophy. These are the things that will make it difficult to interpret. But these are contraindications. So this is something you need to know. Okay. So if there's severe AS, if there's uncontrolled hypertension, severe heart failure, symptomatic arrhythmias, acute MI, if there's suspected pulmonary embolism or aortic dissection, then you can't do an exercise ECG. Okay. Especially remember that a severe AS means you can't do an exercise ECG. So you have to do something like a stress echo or something else, some other stress test to find out what whether there is any ischemic component to his pain, but you can't do exercise ECG. So that is the investigations when it comes to stable angina. Then moving on to the management of stable angina. So when it comes to management, you have risk factor modification and you have management of the stable angina per se. That is a pain, chest pain. So risk factor modification, we know that's also your pharmacological, non-pharmacological. I have a small, I think I sent this note to you all neither. So you can read that non-pharmacological. That is basically you're managing your hypertension, dyslipidemia, diabetes mellitus, and smoking. Another thing I want to say is that these things, now in my long case, I also got MI, but he had MI heart failure and he had a small component of heart failure and he had COPD also. Okay, so because he has his main, he didn't have any other comorbidities, his main risk factor was smoking. So in my case, everything, they asked so many questions about smoking. Okay, about how will you manage smoking. Then they asked about what are these replacement therapies for smoking. Remember, there are 5 replacement therapies in psyche also, you will need it now. So even in psyche, remember to study smoking in detail because they will ask that for other cases also. So they asked me what is the mechanism of action of nicotine replacement therapies. Like she wanted to know what is the action of that chewing gum. Okay, what is the mechanism of action of the chewing gum. Then she asked whether there are any drugs to use for smoking patients. So then you have varenicline, bupropion, those are the drugs you use. And then she was like, what are the mechanism of action of those drugs? So and how will you manage exactly smoking and all that, like that. There will be a lot of questions they can ask on other things. That's why your history has to be a complete history, because they will ask if there are no risk factors for your patient, they might pick up these things and ask a lot of questions on these things. So be prepared to answer, other stuff also if they ask. Then when it comes to this pharmacological management of stable angina, then you have to, there is this method. Okay, I think I'll just tell this, but this is something you might have to study again. Okay, because this is a lot of things to memorize now in this one. So remember that the first line is you have calcium beta blockers, calcium channel blockers. Those are your main first line agents, and it's no longer nitrates. Okay, so your standard therapies you give, just I'll mainly talk about this first line drugs, is your beta blockers or calcium channel blockers. Okay, so we know in calcium channel blockers you have dihydropyridine calcium channel blockers and non-dihydropyridine calcium channel blockers. Dihydropyridine means they finish in denes. Okay, so like amlodipine, nifedipine, nimodipine, they all pins, no, dipine. So those are your dihydropyridine. That's also finishing in dene. So those are also denes. So those are your dihydropyridines. Non-dihydropyridines are the ones that do not finish in denes. That's your diltiazem and verapamil. Okay. So what happens is when you have a high heart rate, you have to use a beta blocker or a non-dihydropyridine. This is because when you give dihydropyridines, they cause a reflex tachycardia. Okay. If I don't know if you can see this. Okay, this there are these tables that are there. Okay, so because dihydropyridines, these are your amlodipine, all of these things, they act mainly on your blood vessels, and they will cause they are potent vasodilators. So because of that, they can cause a reflex. Sorry. Because of that, they can cause a reflex tachycardia. Okay, but your non-dihydropyridines, they act mainly on your heart and they slow the cardiac condition. So they will cause a bradycardia. Okay, so your diltiazem and verapamil cause bradycardia, while dihydropyridines cause a reflex tachycardia. So if the heart rate is high, here more than 80 beats per minute, then you don't give a dihydropyridine because that will anyway increase it. No, it will cause a reflex tachycardia. Whilst a non-dihydropyridine, they will reduce the heart rate. So because they cause bradycardia, it's good to use that. Now, if they have a low heart rate, that is, they have defined as less than 50, then you can give your dihydropyridines because we know that they don't reduce the heart rate even more. When non-dihydropyridines cause bradycardia, this causes reflex tachycardia. So give this. If there is left ventricular dysfunction heart failure, we know that calcium channel blockers are contraindicated in if there is heart failure. So you have to use only beta blockers. Then low blood pressure means you can use low dose beta blockers and you can use non-dihydropyridines again because non-dihydropyridines will not further reduce the blood pressure like dihydropyridines, right? Because they cause vasodilatation of dihydropyridines, so that will further reduce it. So because of that, you can give non-dihydropyridines. Then your second line agents, no need to know this in detail. I'm just telling you second line agents you can use are these long-acting nitrates, then ivabradine, ranelazine, nicorandil. Okay, if you look at Province's note, he has given it in detail as to how to use these drugs, the mechanism of action of each drugs, what are the contraindications to use these drugs. These things, if you know it, it's good. Okay, so avoid diltiazem, verapamil, like I said, in heart failure. Mainly this thing. Sir has said amlodipine is safe, but usually we don't give. But it makes sense that diltiazem and verapamil are the main things you want to avoid. Then in PVD, we know that you don't give beta blockers because they can cause peripheral vasoconstriction. So then we give calcium channel blockers are the favored one. Okay, so those are the things you can give when it comes to your management, your anti-anginal medications. Okay, so when it comes, so that is the main management of stable angina. So other management, other drugs that you will use, like I said before, another one is you need to know what are these event prevention or survival benefit drugs when it comes to your stable angina. Those are your aspirin and clopidogrel. You don't give dual antiplatelet therapy for stable angina. It's only one antiplatelet that you will give. ACE inhibitors are also shown to have survival benefit, but in those with heart failure, hypertension, and diabetes mellitus. Statins should be used in all patients and they have survival benefit in all patients. So only these three drugs have survival benefit in stable angina. Okay. So the other drugs that you can start, I think these are just additional information that is there in the same thing as Province's note. Just read these things and see if you get time. The other one is these targets. Okay, in this, when you're managing the comorbidities, remember hypertension target is 140/90. LDL target, this they had asked last time for some people in the exam, is less than 55. Okay, and what are the drugs you can use for diabetes mellitus with those with ischemic heart disease? These are all cardioprotective agents. Okay, so ACE inhibitors is what we use because of renoprotective in diabetes mellitus, and also ACE inhibitors you're using not for diabetes mellitus per se, but if they have diabetes mellitus and hypertension, and also if they have ischemic heart disease, anyway, you're going to start ACE inhibitors. Then SGLT2 inhibitors and GLP-1 agonists also have cardioprotective effects. Okay. So yeah, that is your stable angina management. Is there anything you want to ask in that? Stable angina now is known as chronic coronary syndrome. That's a new term. CCS, chronic coronary syndrome. If that's okay, then we can move to ACS.
Yeah, Macha. Understood.
Okay. So then moving on to ACS. Now we discussed. Now this will most likely be your case if you get it. So when it comes to ACS, you have to talk about the management. This is what they will ask you. You know, how are you going to manage? So when the patient comes to the ET, you say that you will do. Sir has done it, written it very well. So you just say that there is a timeline not to do this. So this is the timeline. So within 10 minutes, you can say, when according to the European Society of Cardiology guidelines, it suggests that the ECG is done within 10 minutes of admission. So within 10 minutes you have to do, within 10 minutes you need to diagnose and do the ECG. But before doing the ECG, you have to start giving all of your these things. Okay. Ideally, you have to first give oxygen. If you check the saturation, and if it is more than 94%, you can no need to give oxygen. If not, you give oxygen. Then with the history is suggestive of a ischemic type chest pain and history is suggestive of ACS, you can start your loading doses immediately. So you give aspirin 300 milligrams, clopidogrel 300 milligrams. They crush it and give it in the ETU, if you have seen that, and then they give that, and then you can offer pain relief. But what you can say is that giving morphine is not a very good evidence. Okay, so the evidence level is level 2 evidence, which means that morphine does not have a very good evidence in giving pain relief, because what they say is your other therapies itself will relieve the pain. Okay, but remember, when you're giving morphine, you have to give it intravenous and not IM, and that is because when you give it, you're going to thrombolize this patient. So if you give it IM, if you might thrombolize this patient, then if you give it IM, they might form a hematoma. Okay, or anticoagulants and all of those things that you give might cause some problem if you give it IM. Then always when you're giving morphine, you have to also give an antiemetic. That is why we give IV metoclopramide. Okay, so these doses are also good to know. Morphine is 5 milligrams, means it is not, this is not the the dose for morphine is 0.1 milligrams per kilogram. Okay, IV dose of morphine is 0.1 milligram per kilogram. The oral dose is, you have to check for bioavailability and calculate it. I can't remember exactly. I think it's 0.5 milligrams per kilogram, but I might be wrong. But just know that the IV dose is 0.1 milligram per kilogram for morphine. Metoclopramide, we give 10 milligrams IV. Okay. We give 5 milligrams for morphine for everyone, because we assume that their weight is 50 milligrams. Okay. 50 kilograms. Then you have to order your blood after you do all of this. Then within 10 minutes, order the ECG, and also send, if the ECG is suggestive of a STEMI, then you don't have to take cardiac biomarkers, because we know STEMI means it is clearly in your ECG, you can diagnose as STEMI. So you don't have to do any troponin to diagnose, to further diagnose it. But if it is a non-ST, if there are no ST elevations, but there are ischemic changes in the ECG, then you have to do but you have to do troponin levels in order to differentiate whether this is non-STEMI or whether this is a unstable angina. Okay. So let's first talk about the STEMI management. So STEMI management, your options are, you have to do a primary, you can do a primary PCI, or you can do thrombolysis. So primary PCI, you will say that once this patient comes and all of that, I will, you'll have to consult with the cardiology team and check whether there are primary PCI facilities available if there are no contraindications to this procedure. And then once you have contact the team and the team says that there is facilities, then you will transfer the patient for primary PCI to the cardiology unit. If there are no facilities, then you have to thrombolize the patient. So thrombolysis, also there are time limits, right? So what are these time limits for PCI and thrombolysis? So when it comes to, once you have made the STEMI diagnosis, right? So he said, no, when it comes, initially you have to do the ECG in 10 minutes. So once you have made that STEMI diagnosis, then you have to see what is the time to PCI. If the time to PCI is, if you can do the PCI in less than 120 minutes, then you have to go through the primary PCI strategy. That is, you're going to go for PCI. And if you can do it in less than 100, if you that is you're estimating and you're saying, okay, I think I can do this in 2 hours. So if you know that you can do it in 2 hours, then you have to do it in less than 90 minutes. Okay, that's what they suggest. You estimate that you can do this within 2 hours, then you have to do it less than 90 minutes. Then let's say it's going to take you more than 2 hours. Then you will say, okay, no, we will go for thrombolysis, and that is what you will do. Thrombolysis has to be done in less than 10 minutes. So ECG in 10 minutes, then you assess whether you do the ECG, it is STEMI. Once you have diagnosed that this is a STEMI, you are in a non-PCI center. Okay, this is in a non-PCI center. You think that the transfer can be done in less than 120 minutes. Then you do transfer the patient and get the PCI done in less than 90 minutes. You think that it can't be done in less than 2 hours. Then you do the thrombolysis within 10 minutes. Then let's say you go directly to a PCI center. If you go directly to a PCI center, you do the ECG within 10 minutes, you diagnose STEMI, and then you do the primary PCI within 60 minutes. Okay, so these things you might have to memorize it, and you might have to go through this again and just memorize this and see. Okay, just to know these time limits. Okay, just know that.
This 120 90-minute business, is that to completion of the surgery or the initiation of surgery?
Initiation.
Initiation.
Yeah.
Okay.
Yeah. This leaves that out. Yeah. So this is another thing that, so that is your how you choose which management to do. Okay. Yeah. Then what are you going to do? When are you going to do PCI? Now, PCI is always preferred if the patient who are at high risk, okay? And if they're hemodynamically unstable with left ventricular failure, and if they have cardiogenic shock and they have a very high risk of bleeding, then it's always good to do PCI irrespective of the time. Okay, so irrespective of this time limits, if you can do PCI, if this patient comes with all of these features, then do PCI. Okay. Yeah, so this is a thing that I have said. Go with these timings. These are the recommended new ESC guideline timings. So thrombolytic therapy, this and all, you know this, we give tenecteplase, that is recombinant tissue plasminogen activator is what we give. And we know tenecteplase, and I don't think they will even ask about how to, compare streptokinase and tenecteplase, because streptokinase is not used at all now. So but if they ask you, just say that tenecteplase is streptokinase should be given as a infusion. Tenecteplase can be given as a bolus, and then tenecteplase has less complications and better reperfusion rates. Streptokinase has higher complications. It has a higher risk of allergic reactions, hypertension, and all of that compared to tenecteplase. Okay, I don't think they will ask. Then after that, you have to give. You need to know how to give tenecteplase. So how do you give tenecteplase? Tenecteplase is, you need to give first initially before giving tenecteplase. You have to exclude all of these contraindications. Okay. Now again and again they tell us you don't need to memorize these contraindications, because even they also check it and only on a app or something and only do it. But they have asked in MCQs before, even for our therapeutics exam they asked. So I don't know, but I don't memorize this because it takes a long time to study this, and I don't think it's worth. Just go through it overall if you can, like this blood pressures and all of that, which are elective contraindications. If you can, just go through this. But yeah, if you can remember, it's good. If not, it's okay. Just remember some main one or two like that, in case they ask in the long case. So then how do you give the tenecteplase? Initially give IV enoxaparin. Like I said, that is a half dose. So usually they give 30 milligrams, and then they're going to give tenecteplase. So tenecteplase is only given as a bolus. So how will you calculate the dose of tenecteplase? Just say that tenecteplase dose is calculated according to the weight. That's enough. Okay. Then because they also have to look at a guideline and only a small algorithm to calculate it, which is already given. You don't need to know exactly how to calculate it. Then after that, what are you going to do? You're going to treat again with subcutaneous enoxaparin. So IV enoxaparin, then you're giving tenecteplase, then you're giving subcutaneous enoxaparin. Now that subcutaneous enoxaparin you're giving, whatever dose you give, that is considered your first dose of subcutaneous enoxaparin, not the IV enoxaparin. Okay. So let's say you give an IV enoxaparin 30 milligrams, and then you give tenecteplase, let's say a certain milligrams, and then you're giving subcutaneous enoxaparin 1 milligram per kilogram, one dose. Now that is your first dose for those number of doses that I told. When I said 10 doses, 6 doses, 4 doses, that second enoxaparin is what you consider. Okay, it is a subcutaneous enoxaparin that is considered for 10 doses, 6 doses, 4 doses. Okay, now was that understood? Yes.
Yeah, that doses, that subcutaneous enoxaparin doses are like in STEMI 10 doses, non-STEMI 6 doses, and unstable angina 4 doses. Okay.
Yes. Yeah. Yeah.
BD.
12
yeah.
12 BD. Okay. BD. Okay. So 4 doses is a total doses. Okay. Total number of doses. You have to give it BD.
Yeah. Okay.
Then how do you know that the thrombolysis has worked? Okay. Usually they do a repeat this thing ECG at 90 minutes after giving your 10 hectoplasm. You have to repeat the ECG in 90 minutes. But in that ECG, it will show a 50% decline in the maximum height of ST elevation. Okay, that is how you know. Another thing is that there will be chest pains that will diminish. So chest pain reduce. I'll tell you three things. Wait, I have written these three here. So one is, remember that your chest pain will reduce by 90%. Then ECG ST elevations will reduce. Okay. Now the worst elevated lead will be there now in your first ECG. There will be more than 50% reduction in the ST elevations. Another thing is that you will have this reperfusion arrhythmias. Now with this reperfusion arrhythmias, what you need to know is that the commonest reperfusion arrhythmia is sinus bradycardia. Okay, that is the commonest one. But the most specific one is your accelerated idioventricular rhythm. Okay, so accelerated idioventricular rhythm is your most specific one, but the commonest one is sinus bradycardia. So this basically what this accelerated idioventricular rhythm is. Basically, it's like VT, but your heart rate is less than 110 here, and you have these broad QRX complexes, which are basically less than a heart rate of 110. Okay, that is what you need to know. Just know that you get accelerated idioventricular rhythm and sinus bradycardia. Sinus bradycardia is the most commonest one. But you have this accelerated idioventricular rhythm, which is the most specific one. Okay. Then remember, if there is in case your PCI, in case your thrombolysis fails, okay, you do the thrombolysis and it is failed, then you have to go for a rescue PCI. The next step is going for PCI. Okay, that is your rescue PCI. So what are the other drugs you need to give? Now, remember, you have to give aspirin. So once you initially give the loading doses, no, then you have to convert to aspirin 75, clopidogrel 75, and you have to give high dose statins. Okay. Now, high dose statins, here we don't give very high doses. We don't give 80 milligrams. We give like 10 milligrams. So, sorry, we give 40 milligrams of atorvastatin, and other, I think rosuvastatin is 20. Like that, we give not very high doses, but we don't give 80. Okay, in Sri Lankans, you don't need to give such a big dose, but you say high dose statins. Okay, then you have to start this patient. Like I said, you continue the other initial low molecular weight heparin. So like I said, because in elderly and patient with renal dysfunction, you can't give that same dose. You have to reduce the doses. Okay, usually they give the half dose as that main dose. Then this one, unfractionated heparin infusion. I think when we did the medical appointment, because there was this shortage of drugs, they used unfractionated heparin. But I don't think they will ask that. But if you're doing unfractionated heparin, you need to keep monitoring your APTT, and your target APTT is about this time 1.5 to 2 times the control value. Okay, so remember, APTT will come in seconds, not, it won't come like this, but you know your control value in APTT is certain seconds or 30 seconds or whatever, and that your target should be 1.5 to 2 times that normal value. Okay, so we check APTT every 6 hours when you're giving this heparin infusion. The heparin dose, I can't remember it now. I think it's, you give 5,000 international units of, you give 1,000 in a bolus, and then rest of the 4,000 over 4 hours or something. I can't remember. Okay, that thing they won't ask you, because that is something that they did only because there was no enoxaparin, and sorry, there was no, because there was no tenecteplase and all of that. Only they gave unfractionated heparin, but that is not something that they do now. Okay, I think it should be there in Senekas's book. You can check that. Then other one is, you start these patients on ACE inhibitors and beta blockers if there is no contraindications as usual. Okay, so these are the other drugs that you start in these patients. Another thing that I would want to tell you here that they can ask is, yeah, remember that the troponin that we do now is this high sensitive troponin. Okay, we do high sensitive troponin assays. It's not this one, so we don't use these things now. So high sensitive troponin assays is what we do, and you can detect it in 1 hour itself. Okay, so you don't have to wait for 6 hours like those days to do it. Within 1 hour itself, you can detect the this thing. But ideally at least 3 hours. But even within 1 hour, 1 to 3 hours, you can identify the troponin levels will be elevated. Okay. This will come. I just want to talk about the management. Yeah. So here, you need to know something about this. If you have time, just study what are these evidences for MI drugs. Okay. So we know that you have this what event prevention or mortality benefit with your aspirin, clopidogrel, dual antiplatelet therapy has mortality benefit. Then we know that your statins has mortality benefit. Then we know AC inhibitors has mortality benefit. You have beta blockers have mortality benefit. Like that, there are different but evidences for these drugs. If you have time, just study this. Okay, it might take some time to memorize this thing, but yeah, only if you have time. So that is this thing, STEMI. Is there anything you want to ask in STEMI? Another thing is this reperfusion therapy, you can only do it when they come within 12 hours. Okay. So if it is if it is after 12 hours, if there is ongoing chest pain, then you can thrombolize the patient, but we don't do PCI usually. Okay. So 12 hours is that cutoff. But if there is more than, let's say he had chest pain, but now he's coming after 12 hours and there is no chest pain, then what is the management? You have to give only enoxaparin. Okay, that 10 doses of enoxaparin is your management only. The same if there are contraindications. Let's say there's contraindication for PCI, there's contraindication for tenecteplase. You can't give either of that. You only give the anticoagulation. That is, you only give enoxaparin 10 doses. Either if they're coming after 12 hours, no chest pain with STEMI, you're giving only enoxaparin 10 doses. Same way, if they're coming with chest pain, but they have contraindications to thrombolysis, contraindications for PCI, then also you have to give 10 doses of subcutaneous enoxaparin. That is the only management you can do, even though it's STEMI. Okay.
Yeah, man.
Anything?
what are the contraindication for PCI?
PCI contraindications are,
One is that time duration.
Yeah.
Contraindication, no, not evidence, no work. It's not working.
There is contraindications also. Second, remember, like I said, I didn't study any of those contraindications because I can't remember.
But we didn't do PCI within 2 hours, ne?
Within what? Yeah, that is what?
Within 2 hours, or when the patient came to the hospital only, we calculate that time into 2 hours. Okay.
Yeah. After diagnosis.
Okay. If the patient have a chest pain and after 12 hours he came,
then you can't do PCI. That's why I said 12 hours means that 12-hour cutoff is there. If you can't do PCI, if they come after 12 hours even with ongoing chest pain. If there's ongoing chest pain, then you have to thrombolize. Okay. If there is no chest pain, then you can't thrombolize even.
Okay.
It's understood.
Majan, then this door to needle thing, and is it like so? You said it is after diagnosing. So if patients comes around like 2 hours chest pain, the onset of chest pain is 2 hours before he come into the hospital. At the 2 hour interval, he came to the hospital. At that point, it's already 2 hours, but at the same time, they diagnosed that he's having a STEMI. So there, can we do the PCIO or not?
I didn't understand what you asked. Wait, I'll show you a diagram. Will you? You might understand it after that. Wait. Okay. Now in this thing, what did you ask? That's it. Tell again, will you?
The patient's symptom onset is 2 hours before he's coming to the hospital.
Okay. Now here I'll just show this diagram. There is symptom onset. Now you're saying that there is pain before 2 hours, right? 2 hours.
Yeah.
Okay.
He's having like ongoing pain and everything, and he is coming at 2 hour time point.
Okay.
Time point. Then as soon as they come, they take a ECG, and at the the 2-hour point, now they have diagnosed that PCI is STEMI. At this
Okay.
point, are we going to do PCI or not?
You can. See, that's what I said. In up to 12 hours, you can do PCI. Okay. If after 12 hours doing PCI, within the first 12 hours, you can do PCI. Okay. The PCI which is recommended. Now, if you look at this thing, what they say is within the first 3 hours, this needle is bigger. That is because they say fibrinolysis is preferred within the first 3 hours. But let's reduce that. We are always saying that primary PCI is better. Okay. We'll just say primary PCI is better. But within the first 12 hours, you can do primary PCI and thrombolysis. Okay. But if the patient comes after 12 hours, then, wait. First I said it the other way around, neither. I think I said that after 12 hours, you have to do fibrinolysis, right? That's what I told you.
You said like that after 12 hours, until
Yeah.
up to 12 hours, PCI can do, then after that, thrombolysis.
No, it should be the other way around. Okay, you can do up to 12 hours, you can do both. Okay, remember, up to 12 hours, you can do primary PCI and you can do fibrinolysis. But after 12 hours, we don't do fibrinolysis, you can do PCI. Should be the other way around. Okay.
Up to 12 hours, you can do both. After
Yeah.
12 hours, you have to go for primary PCI.
Yes, if there is ongoing chest pain, okay, that
Ongoing
chest pain thing, yeah, if there's ongoing chest pain, then you can do that. Yeah, wait, I think.
So this 2-hour business, 2-hour business is from the diagnosis.
Which 2-hour business? Yeah, that 2-hour business is from the diagnosis, from the ECG diagnosis. Yes.
Okay. Thank you.
Here, this is that picture. This is what I made, that I told the other way around. From 12 hours onwards, it's after 12 hours, you don't do fibrinolysis, you do PCI. Okay, that's what I made the mistake. But that is only if they have symptoms. Like they said, no, if they come with chest pain, then you do this. But if they are asymptomatic, then you don't do, because the evidence levels is less for that. So if it's asymptomatic, you give only the anticoagulation. Okay.
Yeah.
So correct that time. What I said before was wrong. I said after 12 hours, you don't do PCI, but after 12 hours, you can do PCI, but don't do fibrinolysis. It should be the other way around. Okay.
So after you only enoxaparin, no? After 12 hours, it's symptoms.
After
10 doses of enoxaparin.
Yes, after 12 hours, no symptoms, 10 doses of enoxaparin. After 12 hours, symptoms, PCI.
Thank you. Understood.
Is everyone okay with that? I made a mistake when I said that. Is that everyone okay? Did you understand that what I said after that I correct the correction? Was it understood?
Yes.
Okay. Yeah, so that is to do with your STEMI. Then going on to non-STEMI. So non-STEMI and unstable angina, they are mostly managed the same. Again, it's the same thing. You do the 300 milligrams aspirin, clopidogrel, high dose statins as your loading doses. Prasugrel, ticagrel, no need to know. Then you can give oxygen. Same thing, morphine, then metoclopramide. But here, after you do the ECG, you have to do the troponin to check whether this is non-STEMI or whether this is unstable angina. Okay, so here the main management is anticoagulation. But remember that even in non-STEMI patients, when they come with like very unstable cardiogenic shock, or when they're with left ventricular dysfunction, life-threatening arrhythmias, cardiac arrest, and all of these problems, then they have to go like STEMI, you have to do urgent PCI within 2 hours. Okay. This is the recommendation for non-STEMI patients who are coming with all of these problems. So that is called the gray score, where they put these things and check whether that patient has a high risk based on the gray score. And if it is falling under the high risk, then they do a urgent PCI within 2 hours. Okay. But if the risk factors are intermediate, then you should ideally undergo a coronary angiogram within 24 to 72 hours after you do the anticoagulation. Okay, this is the ideal thing. even after, if they are not high risk, but they have certain intermediate risk factors, then after you do anticoagulation, the patient has to go within 24 to 72 hours after you start the anticoagulation. The patient should go coronary angiogram. Okay. So these are the anticoagulant agents. You can use unfractionated heparin, low molecular weight heparin, the same way I said, non-STEMI 6 doses, unstable angina 4 doses, and you can use this agent called fondaparinux also, which is a more specific drug rather than these two. We know unfractionated heparin is non-specific. Low molecular weight heparin is even more specific. Fondaparinux is also specific. So your bleeding risk will be less. The other one is the same. You give antiplatelet therapy, dual antiplatelet therapy for minimum 1 year, and then you have to convert for lifelong single antiplatelet therapy. Then give high dose statins, ACE inhibitors, beta blockers. This is just if they are hyper diabetic, then you have to have target of, usually it's between it's less than 180 or 140 to 180. Okay, remember that when you're discharging the patient, before discharge they have to undergo a 2D echocardiogram. Okay, all these patients need a 2D echo before discharge. And those drugs that you need to start, just know the mechanism of action of those drugs also. So here what I want to say, other one is this MI, post MI complications. This is something that you have to divide and study in the terms of your duration. Okay, so immediate, early, intermediate, late. This is something they ask from me in the long case also. What are the complications? What are the immediate, early, the intermediate? So this is something they will ask, a common question. No, even in MCQ they will ask. So what are the immediate complications? Arrhythmias, your heart blocks. Mainly your heart blocks you will get with this inferior MI. So that affects your SA node and AV node. Then early ones, you can get this papillary muscle rupture and lead to acute mitral regurgitation, which can lead to acute heart failure, or they can just get acute heart failure due to just the MI itself. Then intermediate, they can get septal ruptures with VSDs, then left ventricular pseudoaneurysms and rupture of the free wall. If there's rupture of the free wall, that is, free wall gets ruptured, then they can get a cardiac tamponade. Late, they get this true ventricular aneurysms and Dressler's syndrome. Dressler's syndrome is an autoimmune phenomenon where they get this pericarditis. Okay, post-MI pericarditis can occur in the acute stage as well, and it can also occur late. If it's in the acute stage, we call it post-infarction pericarditis, and if it is later onwards, we call this Dressler's syndrome. Okay, so this thing is something you might have to study again. Complications. I think that's all to do with MI. These things, I think it's a little too much. I don't want to know this. They want to ask. This ST elevation, the way it changes, that is something that they might ask. Okay, how it changes. Initially, you get these hyperacute T waves. That is the earliest sign of the STEMI. The STEMI's earliest sign is hyperacute T waves, which occurs within minute to hours. And then you get this tombstone ST elevation. That is the ST elevation that you see. Okay, so this is how it changes, ST elevations. And then that will be there for about 2 to 8 hours. And then after 12 hours, you get, with the STEMIs, you get this transmural infarcts, you get these Q waves. Okay, so initially in the ECG, you get hyperacute T waves, then this ST elevations or tombstone ST elevations, and then they get Q waves. Another thing to study is these things. Okay, study the leads. What leads show what. They might give you an ECG in long case and ask you. So if it lead 1 and AVL will tell you the lateral leads. So what are the arteries that covers the left circumflex and diagonal arteries? Then you know that 2-3 AVF is the inferior one, so that will give you your right coronary artery more. Then septal leads are V1 and V2, that is left anterior descending. Then anterior leads are all of this, V1, V2, V3, V4, again left anterior descending. And your V5 and V6 also gain the lateral leads. Okay, so just to recap, lead 1, AVL, 5 and 6 are lateral leads. Lead 1, 2, 3, 4 are anterior leads. In that, lead 1 and 2 are septal leads, and 2, 3 AVF are your inferior leads. And the arteries that correspond are written here. You have this note now? I sent this note on that first day.
Yes, sir. Yes.
Okay. So that is all to do with MI and ischemic heart disease. Anything you want to ask from that?
Madan, one more thing. When we are discharging the patient, what are the drugs that we must give now? We are giving to antiplatelets. Apart from that, the mortality benefit drugs is in inhibitors. And what are the other drugs? Usually, you are atorvastatin and about of statins. Those four drugs.
Other one is beta blockers.
Beta blockers.
Yeah, that's all.
5 drugs. So
Yeah.
okay, thank you.
Anything else? I think I have to do heart failure also, neither.
Yeah.
So we'll go on to heart failure. Is there anything you want to ask in ischemic heart disease?
I'm okay. Others?
Okay. Others? Okay. Anything to ask?
I'm also okay.
Okay. So heart failure. Give me 1 minute. I'm getting a call. Hello. Sorry. So here, I was told to focus on heart failure. So did anyone do a SOB short long case or with other causes, the respiratory causes and all of that?
No, Madam. No.
No. Okay. So then I'll just tell none of the other causes were done. Asthma, COPD, bronchitis.
Asthma, a surgeon did, but not the SOB per se. COPD, surgeon did, but it's also not covering all the shortness of breath from the COPD perspective.
Okay. So I'll just do a small introduction on shortness of breath with in focusing only on heart failure, but you will have to rule out the other causes well. Okay. So what you want to do in shortness of breath is you have to, when you get a case with SOB, always think of all the systems that can get affected. Okay, so do cardiac, then do respiratory, then do renal, then hematological, then thyroid or whatever. And like that, you divide the not thyroid, but you divide the causes and you write what are the causes that can cause shortness of breath and ask according to those systems. Okay, so initially. When it comes to the presenting complaint, you don't know how to deal with that as to what is the shortness of breath that the patient presents with. So you say, Mr. Pereira, 56-year-old male who is a carpenter from Kotahena and a father of 2 is currently presenting with shortness of breath for whatever duration, or shortness of breath for exacerbation of shortness of breath for 6 hours duration on a background of shortness of breath for so many months. Okay, that means you can say that he has a history of heart failure. That is what you're trying to say, but he's currently coming with an exacerbation of the heart failure. So you say he has a history of heart failure. That's why you're saying you has a baseline shortness of breath for this much of duration, but now coming with a exacerbation of shortness of breath. Okay, so again, it's the same thing like the pain, where you need to ask about the onset, the evolution, and progression of that shortness of breath. What are the exacerbating factors and what are the relieving factors, and what are the associated symptoms with this shortness of breath? Okay. So then you ask about what are the differential diagnoses. Like I said, again, it's the same way of you rule out. You go with, remember when you're doing your history of presenting complaint, always start with symptom analysis, then by etiology. So you're going to talk about the differential diagnosis. And once you have narrowed down a differential diagnosis, you ask about the risk factors there itself. And then you need to talk about complications and what has been done so far. Okay, so when it comes to shortness of breath, when you're talking about cardiac diseases, it can be either heart failure, which is what we're going to focus on today. It can be valvular heart diseases, which can also cause shortness of breath. Pulmonary diseases, since it's COPD, asthma, and bronchial malignancy. Now, in a case like that I got, it was a little bit difficult for me to say whether this patient's, because he had COPD, he had an exacerbation of COPD 1 week ago, he had MI, and he was propped up, and he said that he had difficulty in breathing with orthopnea and PND also. So my issue was whether this patient has COPD that is causing the difficulty in breathing, or whether he got an MI and got a heart failure component to it. So I presented it as it's mainly a heart failure component that is also associated with this MI. So that is something that you might have to differentiate when you're taking the history, whether this is a COPD induced shortness of breath, or whether this is a heart failure induced shortness of breath, because you can get these cases that are all mixed. You can have an MI patient coming with difficulty of breathing with this thing as well. Okay, because this patient had a lot of wheezes on his on examination of this thing, but the wheezes were mixed with a little bit of this thing as well, but creps as well. So it was a very weird sound that you heard on auscultation. Another thing, when it comes to your examination also, sometimes remember that patients can be given diuretics. So when you get the diuretics, they might still complain of orthopnea and PND, but you might not hear fine crepitations on your examination if they have been given these diuretics. Okay. So then the first thing is you can have cardiac failure, valvular disease, heart diseases. Pulmonary heart disease, you can have COPD, asthma, or it can be some bronchial malignancy or any other in ILD and bronchial cases. Then it can be renal disease. Renal disease can be, you can have CKD, and that causing fluid overload and pulmonary edema, or it can be anemia. Now, in heart failure, remember heart failure, when you're talking about this cardiac disease, heart failure, your heart failure shortness of breath is exertional shortness of breath. So they will usually complain of an exertional breath. That means when they get this difficulty in breathing on walking or on climbing stairs or whatever like that, whenever they're working. They will have other features like your orthopnea and paroxysmal nocturnal dyspnea. Now, these two are not going to be there in your, but in the other respiratory conditions. So these are specific to your heart failure symptoms. So you need to ask, when you're asking about this orthopnea, remember to ask how many pillows they are using. And if they ask the mechanism of that, that is because when you lie flat, there is a redistribution of your pulmonary circulation. So the fluid gets redistributed, and because that's the is a V over VQ mismatch, and with that you get this orthopnea. Okay, if you tell like that, it's enough. Then you have to also have to ask about this PND. Now, PND usually comes without a warning, and where they wake up in the middle of the night and they have this anxiety, chest tightness, shortness of breath, palpitations, and cough. And you have to stay sometime. They have to open their windows and rest for a little while and stay for it to reduce before they can go back to sleep. Okay, it's not like you can get up and go back. It's not like that. They have to rest. They have to breathe a little bit. They have to need air to breathe and all that. Then only they go back to sleep. So remember to ask that properly when you're asking about PND. So to actually define, is this really PND or not? Okay. Then they will have this pink frothy sputum at the nights usually because of this redistribution of fluid and all of that. And they will have, because of the pulmonary edema that is associated with it, they can have pink frothy sputum as well. Other things you need to ask of if there is any ankle swelling that they have developed and any lower limb swelling as well. Then about this etiological clue, like I said, it depends on the case you get. You have to ask about symptoms of ischemic heart disease, like the same things that I told there about whether they have had the history of any ischemic symptoms. So that is what you will ask mainly on the history of chest pain. Okay, of heart failure with SOB associated heart failure. Okay. And this is your valvular heart disease, means you need to ask about history of rheumatic fever, palpitations, and if they have had any cardiac syncope, which will indicate aortic stenosis. So maybe I'm focusing mainly on heart failure. So just mainly for heart failure, ask about these symptoms. Okay. In your examination heart failure, you will look at for the if there is any cardiomegaly that is in, if there is dilated, if the heart is apex is displaced or not, if your JVP is elevated, remember, and end inspiratory basal crepitations. Now also remember that you need to match your examination findings with your symptoms as well. So if there is orthopnea and paroxysmal nocturnal dyspnea, then you will expect the patient to have inspiratory basal crepitations. Okay, so that is unless the patient is on diuretics and the edema has reduced, then you won't hear this. But if not, you will expect to have this. So this orthopnea and paroxysmal orthopnea can be you can have in both right and left heart failure, but PND is mainly you will get it with left heart failure because you need to develop pulmonary edema to get this. Okay, actually orthopnea and PND both you will get it only with left heart failure, but SOB you can get it in either. Okay. Then JVP elevated, you can get it, you will have it mainly in right heart failure and congestive heart failure as well. So yeah, then I will skip all of that and go to this thing. In examination is what I said, look for anemia, same thing as that. Look for these things. Murmurs, check if there are murmurs. Murmurs itself, even ischemic heart disease, like I said, it can cause an MR, and then the MR can cause heart failure. Look for any added sounds like an S3. Abdomen for respiratory, look for fine crepitations, bibasal fine crepitations. Abdomen, look for if there is liver, enlarged liver, and if it is tender, and also sometimes cardiac failure, if it is severe, can cause ascites. So check for ascites. Nervous system, if you have time. Okay. So then moving on to heart failure. When it comes to heart failure, you have this etiology mainly. You have these 5 main etiology. Okay, one is ischemic heart disease, then hypertension, then anemia, then it's your valvular heart disease like mitral regurgitation, and another one is your rheumatic rheumatoid arthritis. And this rheumatoid arthritis is considered an independent risk factor. Okay, for ischemic heart disease and also for heart failure as well. So they can have all of these causes, and there are other causes also like alcoholic cardiomyopathy and all of those things, which other cardiomyopathies, dilated cardiomyopathy. But these are the main 5 causes that you can think of and that you need to ask in your history. Okay, rheumatoid arthritis, you can ask if the patient is a female patient and has other symptoms of that. Okay. So remember, you come with your heart failure diagnosis based on your clinical suspicion, your clinical grounds, and then you will establish your diagnosis of heart failure based on these investigations. So what are the investigations you're going to do? Initially, your only main form of investigation that you can do to diagnose heart failure is your echocardiogram. Now, another thing they asked me also in my case was, how will you investigate the heart failure component at the ETU? Okay, now at that point at the ETU, you can't order an echocardiogram, no, but what you can do is something called POCUS. Okay, POCUS. I'll just write this here. POCUS on the chat. That is point of care ultrasound scan, which is something that they also use to check the ejection fraction. So they can check the ejection fraction using this at the ETU. Okay. So that is something that they can detect heart failure if the patient has heart failure there, and also it can detect that ultrasound scan you can do to detect pulmonary edema and all of that as well. Okay, then you will also so that is the main thing. But if you want to properly diagnose, you have to do a proper 2D echocardiogram. Okay, so what are you looking at? You're looking at the ejection fraction. Now remember, heart failure has both you're looking for the ejection fraction because you can classify the heart failure based on the ejection fraction. It can be a preserved ejection fraction, it can be a reduced ejection fraction, it can be a modulatory reduced ejection fraction as well. I come to that. Then you're looking at this, what is the size of the chambers, what are the size of the ventricles, if there are any regional wall abnormalities. Now, this regional wall abnormalities is what you get after a heart attack or after a ischemic heart disease, is when causes this regional wall abnormalities. Also, with your cardiogram, you can look for any causes. So, like if there is a valvular heart disease, or if there's any cardiomyopathy, that you can find out with your cardiogram. So that's also helpful in diagnosing what the heart failure is and what is the cause of the heart failure. Okay. So, like I said, some people will have a normal ejection fraction, which indicates that there's preserved ejection fraction, which means that there's a diastolic dysfunction. Okay. Another thing you can do is BNP. Now, BNP can be used to check if the patient has heart failure. That is because BNP secretion increases when the ventricles dilate. And then, so in heart failure, we know that there is dilation of these ventricles. So then BNP will increase, and that can be used to prognosticate the heart failure as well. Okay. So remember, BNP is a brain natriuretic peptide that is released by your ventricles to cause natriuresis as a compensatory mechanism to reduce the fluid overload in these patients. Okay, so that is one echocardiogram, BNP. Then you can do ECG. Now in ECG, what you are looking at is this. Okay, when you have this R wave progression, usually you should have a good R wave progression in these chest leads. Okay, so when you look at these chest leads, there's a very good R wave progression. But here, look at this R wave here. Can you see this? Sure. Here, the R wave progression is normal. It keeps increasing, right? In V4, V5, you have the maximum and then it goes back down. But you can see there's a nice R wave progression. But here, you can see the R wave is the same everywhere, right? Only here it's a little bit big, but otherwise the R wave hasn't progressed as good as this. This is the R wave. The progression is not as good. So, yeah, so that is one indicator of heart failure. Okay, that is when you have this poor R wave progression. Then other things that you can do is in the ECG, you can look for other causes like the previous MI, if there was left hypertrophy, if there are any arrhythmias that cause the heart failure. Those are also things that you can see. Then the other one is your chest X-ray. Now in your chest X-ray, there are certain signs that you would like to see in heart failure. One is cardiomegaly. So cardiomegaly is something that you can check in your heart failure. That is if it is more than half, when the entire shadow, the chest wall shadow, if it is more than half of your heart shadow, then you can consider that as cardiomegaly. Okay, then upper lobe diversion is basically when the vessels are more prominent in the upper part of the lungs. Curly B lines are these small lines that you get on either side of the chest X-ray, where that will indicate that there is fluid within this within the spaces that you have within these lung tissues. Okay, then you have this perihilar prominence which can be there. That is on the hilar side you have prominence of these blood vessels, and sometimes you will get these pleural effusions. Okay, usually the pleural effusions are bilateral pleural effusions. So that is when it comes to the investigations. And like I said, this BMP and pro-BMP is something you can do. So was that understood?
Yeah, Macha. Yeah, understood.
Okay. So then moving on to this management. So when it comes to management, like I said, first initially you diagnosis based on, just to recap, your clinical diagnosis, echocardiographer and biomarkers if you want to do. So clinical diagnosis, risk factors for heart failure, and your typical history, shortness of breath, orthopnea, PND, those three, exertional shortness of breath. Then examination will be high JVP, cardiomegaly, pleural effusion, basic trackers. Okay, so that is your diagnosis. You have done your diagnosis, and then you have to go to the management. So now management is initially you classify. So like I said, based on your echocardiogram, you do your echocardiogram, you get an ejection fraction, and based on that, you can classify this. The classification is you can have heart failure with reduced ejection fraction, with moderately reduced ejection fraction, and preserved ejection fraction. So your reduced ejection fraction means your heart ejection fraction is less than 40%. So moderately reduced means it is 40 to 49, and preserved means more than 50%. So this is, if there is reduced ejection fraction, that means there is a systolic dysfunction. That basically means your heart is not pumping enough, right? So your cardiac output is low, your heart is not pumping enough to send enough blood to your organs. That is a systolic dysfunction. The diastolic dysfunction means that is when your heart failure, your ejection fraction is preserved. So the amount of cardiac output that you're giving may be preserved, that not that cardiac output, but your ratio between your stroke volume and your cardiac output is preserved, but and your endostolic volume is preserved, but there is a problem in your filling of the heart. Okay, so heart filling is affected, and that is what is called diastole, because we know in the diastole, when your ventricles relax, that is when the heart fills. So if there is a ventricular diastolic dysfunction, that means there's a problem with heart filling. Okay, so all this management that we talk about is based on this heart failure with reduced ejection fraction. It is not for preserved ejection fraction. So what are the drugs you can give for preserved ejection fraction? Is there is only one drug that has shown to have some mortality benefit, and that is this SGLT2 inhibitors, okay, for preserved ejection fraction. But for reduced ejection fraction is what we will talk about when it comes to the rest of the management. So then you can further classify the stage of the heart failure again based into A, B, C, D. Okay, that is something you can read. And then this NIHA classification, as you know, is what we classify also when you're presenting the history also, you can use this NIHA classification, but only if you know that the shortness of breath is because of a heart condition. Okay, now that is another mistake that people make when they are presenting the history, is that they use the NIHA classification for presenting all shortness of breath. Now you can't do that, because NIHA classification is intended for heart failure only. So if you know the patient is having heart failure only, you can you say that this is NYHA class 3. Best thing is not to use any classification when presenting it, because if you're presenting a respiratory case, then you have to classify it according to the MMRC, that is a Modified Medical Research Council classification, which is basically the same. But you can't say that he has NIHA class 3 classification when the patient has come for a respiratory cause that is causing the shortness of breath. Okay, so don't use NIHA for everything. Okay. Then we'll talk about the management. When it comes to the management, the main things you need to do is you need to manage the etiology, and then you have to do the drug management. So pharmacological management, you have this non-pharmacological management, it's the same thing for everything. Yeah, then we'll move on to the pharmacological management. So before going there, I'll just tell you something about this. The pathophysiology of heart failure, that is, in heart failure, what happens is that we know that heart failure means your cardiac output is equal to your stroke volume to heart rate. So when there is ejection fraction is reducing, that means your stroke volume is reducing, or the other way around, your stroke volume reduces, because then so that your ejection fraction reduces. Okay, so because body has a tendency to increase the cardiac output, it will use the sympathetic drive and it will increase your heart rate as a compensatory mechanism. Okay, so when the stroke volume reduces, your perfusion reduces. So when the perfusion reduces, your sympathetic overactivity increases, then the heart rate increases, then the cardiac output will initially increase, but then it will not get sustained, and that will worsen the heart failure. And also when the heart rate increases, we know that the diastolic period will reduce, and it is in the diastolic period that the heart receives blood supply. So when that is reduced, the further it will increase, the heart will go into, you will experience ischemia more and more the heart failure will get worse. Okay, so most of these compensatory mechanisms that occur are harmful to the heart. So when we treat it, we try to reverse these compensatory mechanisms. Another thing is that in heart failure, like I said, there's reduced perfusion to your organs. So there's reduced perfusion to the kidneys. And if there's reduced perfusion to the kidneys, that is when your renin-angiotensin-aldosterone mechanism gets activated. Okay, so this is your renin-angiotensin-aldosterone mechanism which is getting activated. And this renin-angiotensin-aldosterone mechanism will help to reduce your this thing, right? Your fluid overload is also try to reduce because of this natriuresis and the diuresis that it causes. Another thing is that your renin-angiotensin-aldosterone will cause fluid retention. So that will increase your this fluid retention, and that will further sorry, give me 1 minute. Sorry. Yeah, okay, sorry. Sorry for saying. Yeah, so when it comes to the compensatory mechanisms, one is a sympathetic overdrive that you get, and this sympathetic system will cause an issue, what I said earlier. Other one is your renin-angiotensin-aldosterone mechanism, which also activates, and that causes sodium and water retention, and that is when you get this entire fluid overload system will occur in heart failure. That is because of reduced perfusion to your kidneys. Another thing is that when your heart gets dilated, it releases this ANP and BNP. So that causes natriuresis. So that is the only good thing about this thing, that is ANP and BNP will cause natriuresis, which is good. Okay, yeah, for that and for now that is enough. Another thing that this heart undergoes when it comes to heart failure, MI and all that, is the remodeling. So this remodeling is when there is rearrangement of your heart muscle fibers and fibrotic tissues, and this remodeling, we can give certain drugs to prevent this remodeling as well. Okay, so just as an overview of what I said so far, how are you going to combat these mechanisms? So our drug management combats these mechanisms. One is the sympathetic overdrive, renin-angiotensin-aldosterone system, and then your ANP and BNP, we want to increase that. we want to reduce these two and we want to increase that. So when it comes to your first problem is your fluid overload, right? You anyway have fluid overload because of the renin-angiotensin, all those things. Your heart is not functioning and all that. There is fluid back up into the organs, and there is fluid that is extravascular fluid is high. And then, so you want to reduce that fluid. At the same time, because of this renin-angiotensin aldosterone mechanism, there is more fluid retention within the vascular spaces as well. So you give diuretics, and these diuretics will get rid of the excess fluid in your body. That is why we are giving diuretics. So diuretics are used in all patients who are symptomatic heart failure patients. We give diuretics, but what you should remember that diuretics, you can't, there is no evidence to say that diuretics is beneficial in heart failure. That is because you can't do any trials without giving diuretics, because diuretics has been shown to be so helpful in patients. If you stop giving the diuretics, the patient will die. So it is not ethical to give diuretics. So it's not an evidence-based thing that is there, because you can't do trials without having a control arm who do not get diuretics. Okay. The other one we use is this AC inhibitors, and these AC inhibitors will stop the RAS pathway. So if that stops the renin-angiotensin-aldosterone pathway, then you won't have this sodium and water retention. Okay, so that is also shown to improve survival and reduce your mortality. And then another thing we said is you have this sympathetic nervous system overactivity. So for that, we use these beta blockers for that. Okay, we use mainly cardioselective beta blockers, but you can see there are some that are not cardioselective as well. Okay. So that is thing. So you have these compensatory mechanisms like the sympathetic overdrive, renin-angiotensin-aldosterone mechanism that comes, and we are giving drugs to counteract those mechanisms. One is the AC inhibitors to counteract the RAS, and your beta blockers to counteract the sympathetic overactivity. But now remember that your initial management of heart failure was to give only those drugs at the initial stage, but now we use more than that as well. We use drugs like spironolactone and SGLT2 inhibitors as first line as well. Okay. Now, so spironolactone is a we know the mechanism of action. No, it is a wait. I don't know if I have a picture here. No, I don't think I have a picture. But remember that this one. So these drugs, these 5 drugs are your main drugs when it comes to treating heart failure in reduced ejection fraction. Okay, so these are your first line drugs that are considered now. What is that? One is AC inhibitors or using an ANI. So ANI is a this is a neprilysin inhibitor. So you have a neprilysin inhibitor plus an angiotensin receptor blocker combination. Okay, so it is basically your sacubitril valsartan that we use now. And this neprilysin inhibitor, if you look at the mechanism of action of neprilysin inhibitor, neprilysin breaks down your BMP and AMP. So the neprilysin inhibitor will prevent the breakdown of AMP and BMP, so that you have more AMP and BMP, and there is more natriuresis that occurs. I can't find the picture with mechanism of action. I'll just use this. Sorry, I don't have that. Okay, so AC inhibitors and ANI. So AC inhibitors, we know how AC inhibitors act. They inhibit the conversion of angiotensin into angiotensin 1 into angiotensin 2. So then the effects of the renin-angiotensin-aldosterone mechanism block. Then we have, because we said that is bad. Then we have ANI, which is a angiotensin receptor blocker plus neprilysin combination, which usually sacubitril valsartan that is there, and that the angiotensin blocker part will act in its normal way, and you have the BMP pathway is also affected because of this neprilysin inhibitor. Then we have the beta blockers. The beta blockers is also first line, and that is because it counteracts the sympathetic nervous system. Then we have the mineralocorticoid inhibitors, which is your spironolactone, which acts as a diuretic, which is also now considered as a first line drug. Okay, so that is no longer considered as second line, but it's first line. Then we have the epagliflozin and empagliflozin, which are SGLT2 inhibitors, which are also considered as first line drugs now in heart failure, because they have shown to have evidence of mortality benefit when given SGLT2 inhibitors, and that is also used for heart failure with preserved ejection fraction as well. And the other last one we said was this loop diuretic. Now, loop diuretic is the only one, it does not have evidence, but all of these have evidence to show that there is a mortality benefit. Okay. So when it comes to your second line drugs, you have these drugs such as your ivabradine, nitrates, and digoxin. Now, ivabradine, it slows down the sinus node, and it is only recommended if you have given the maximum doses of beta blockers or if your beta blockers are contraindicated. Now, ivabradine also has a mortality benefit, but to give ivabradine, the patient should be in sinus rhythm. Okay, so it is contraindicated if the patient has atrial fibrillation or any other patient has to be in sinus rhythm basically. Then digoxin has no mortality benefit, but digoxin has a reduction in the hospitalizations. Then your other second line drug is this nitrate and hydralazine combination. And this nitrate and hydralazine combination has a mortality benefit only in African population. Okay. So again, I'll tell you that all these first four drugs are there now. All of these have a mortality benefit. Loop diuretics, this loop diuretics does not have a mortality benefit. Then ivabradine has a mortality benefit. It should be given in sinus rhythm. They can't have heart failure. And only if you have given the maximum, after you have given the maximum dose of beta blockers. Digoxin, no mortality benefit, but it reduces hospitalizations. Nitrate and hydralazine combination has a mortality benefit in African population. Another thing is this, now angiotensin receptor blockers are no longer considered first line. Okay, you can see that it's not there. You can give AC inhibitors or ARNI, but if they are contraindicated to AC inhibitors, then you can give angiotensin receptor blockers. Okay, don't use this in combination. It's either this, or either this. And ARBs, the only some ARBs have shown to have mortality benefit, and this candesartan, okay, has shown to have some mortality benefit. So it's not nowadays, we don't like those days when you don't use ACI, you can use an ARB. It's not like that now. You can use ACB or ARNI, and if they are contraindicated for both of this, you use a ARB blockers, and mainly candesartan has shown some mortality benefit. Okay, so when this has failed, and let's say this treatment is not there, and it fulfills these criteria, you have this second criteria to use. That is, if your left ejection fraction is less than 35% and your QRS complex is less than 130 milliseconds, then you use this devices. So ICD is basically implantable cardioverter defibrillator is what you would use. Okay, and remember that is only mainly evidence is high if the patient has some ischemic heart disease associated with it. And then let's say the patient is in sinus rhythm, ejection fraction is less than 35, and QRS is more than 130. Here we saw QRS is less than 130, we gave ICD. QRS is more than 130, we use cardiac resynchronization therapy, defibrillator, or a pacemaker. Okay, you can use a pacemaker in these conditions. And that is mainly beneficial if the QRS is more than 150. You don't need to know this. Just know that QRS more than 130, you use CRT. QRS less than 130, you use ICD. Just know that it just is enough. Okay, so this is the main management of heart failure. So yeah.
In AR blockers, only this candesartan have this mortality benefit.
Yes, in the
not other one.
I'll show you the evidence.
Candesartan doesn't have anything.
No.
Okay, then if they ask like first line medications in heart failure reduce ejection fraction, AR blockers, false. Okay.
I don't know if I won't answer that, because the thing is, it used to be first line, where so they used to give it.
Inhibitors or ARNIA contraindication. So okay.
Yeah. So then that's a clause is then. So I won't know what I usually leave that.
It's okay.
Okay. Yeah, this is the this thing, the evidence that only candesartan has mortality benefit. Valsartan has only reduction in hospitalizations. But remember that ARNI has a ARBP blocker in it. Okay, but that's a combination. So you have sacubitril and valsartan together. These are the other evidences that are there in heart failure. If you want, you can go through these trials. These are the trials names. So yeah, that is the main thing to tell in heart failure when it comes to this management. Another thing is this drugs. Okay, you need to know something about these medications. So you have to study these adverse effects and contraindications. Remember, in diuretics, you can give furosemide and metilazone. Metilazone is a thiazide diuretic, and furosemide is a loop diuretic. So you should need to know where this acts. Furosemide acts on the this ascending loop of Henle, and it inhibits the sodium. Potassium 2-chloride channel. I can see this here. Yeah, here this channel is there. So sodium potassium 2-chloride channels are inhibited here. Then thiazide diuretics act here in the early DCT, and they inhibit the sodium chloride channels. Then this is where your this thing acts. Spironolactone, it acts here, mineralocorticoid receptor antagonist. Then, yeah, SGLT2 inhibitors will act here in the proximal convoluted tubule. So mainly you need to know this mechanism of actions and what are the adverse effects for diuretics. Remember these things they ask in MCQs also. I think we also got one MCQ with something like this. I can remember thiazide something they asked. Then hyperglycemia, hyperuricemia, hypokalemia, hyponatremia mainly with loop diuretics or thiazide diuretics. And then you can get these symptoms. Then you have these AC inhibitors and ARNI. The main side effects are your angioedema, then cough. Then they also can cause hyperkalemia and postural blood pressure, postural drop in your blood pressure. So these are the contraindications. Remember that significant renal dysfunction you can't give, bilateral renal artery stenosis you can't give, and pregnancy also it is contraindicated. Then angiotensin 2 receptor blockers, they can cause hyperkalemia, but if there is cough and angioedema in ACE inhibitors, we prefer to give angiotensin 2 receptor blockers. Beta blockers, remember, they can cause PVD, impotence, contraindicated in asthma, contraindicated in heart block. Critical limb ischemia is also contraindication. Spironolactone, check for this gynecomastia if the patient is there on examination, because usually if it's a heart failure patient, they will be on spironolactone and they can have this. Then yeah, with SGLT2 inhibitors, what you need to know is it can cause recurrent genital and fungal infections. Okay. Another thing it can cause is it causes this euglycemic ketoacidosis. So in the acute heart failure stage, sometimes we don't use the SGLT2 inhibitors because it causes that euglycemic ketoacidosis. Yeah, other things are in heart failure. What I have to tell is, I think acute heart failure management. Other than that, everything I have told. Chronic heart failure is anything else to study this non-pharmacological management. Okay, that is the same for everything. One thing you might have to read on in this cardiac rehabilitation therapy. That's something that you can read. Cardiac rehabilitation therapy, where you include everything. Okay, it's all of this non-pharmacological like nutrition, diet, exercise, then management of comorbidities, stopping smoking, alcohol, all of that together is something that is incorporated in this cardiac rehabilitation therapy. One minute. Is there anything you want to ask when I find the acute management?
Okay, understood. Others?
Okay. Yeah, okay. So then I'll just this acute management I studied Province's book, emergency book. I think that's good enough for you to study. So here they will come with acute management is they are coming basically with acute shortness of breath and acute left ventricular failure is what they will usually come with. So initially you have to take this history examination all of that and then prop up the patient and give high flow oxygen to maintain a saturation of more than 94. Same thing that we saw earlier. Okay. Then your important differentials we saw before, but additionally just know that MS with pulmonary edema is a possibility when they come with acute acute shortness of breath in addition to your acute heart failure. Okay. So this is something that you don't do usually, but what you can do to differentiate asthma and pulmonary edema is you do the BNP and pro-BNP levels if you can't clinically differentiate it. Okay, because something that even in heart failure they can get wheezes is a common thing with cardiac wheezes can be there, so you can have wheezes in heart failure as well. Okay. So then once you decide that it's heart failure, you assess the degree of congestion and tissue perfusion. Right. I think this is you would first measure whether the patient has any congestion and tissue perfusion. Okay, so we know why this occurs. Congestion is because of the back pressure and all of those things that I told. Initially, there is congestion. So that's why you get this pulmonary edema, you get fluid overload, you get liver congestion, all of that congestion. Tissue perfusion means there's reduced perfusion to the tissues, right? So when there's reduced perfusion, because we know the cardiac output is reduced. So features of congestion, like I said, pulmonary edema, JVP elevated, peripheral edema, hepatomegaly. Those are the features of congestion. Now, features of tissue perfusion are your hypotension, cold extremities, and narrow pulse pressure. So those means that there is reduced perfusion to the end tissues. So if the patient has an adequate tissue perfusion, okay, that means your perfusion is normal blood pressure, and there's evidence of congestion, then you can start diuretic therapy. That is, you give IV furosemide. Okay, these doses you might have to memorize. Some people like to ask doses, no? So just know that there is 40 milligrams of this starting dose, and then if the patient is already on this furosemide, if he's taking, a patient with known heart failure is taking furosemide, then you double that normal maintenance oral dose. Okay, so you give IV, you check for tissue perfusion, you check for congestion. There is adequate tissue perfusion, but there is evidence of congestion. If there is that, then you give IV furosemide. You give IV furosemide 40 milligrams. If the patient is already on furosemide, you just double that maintenance oral dose. Okay, then you can repeat this furosemide bolus every 2 hours, and you can double the dose if the patient does not respond, but a maximum dose is 400 milligrams. Okay, then if you, let's say you're repeating this dose every 2 hours now, and you're doubling the dose, and you can go up to a maximum 400. But if that does not, if you don't want to do that, you can instead give an infusion of furosemide as well. So this is the rate of infusion. So management is initially check congestion, check perfusion. There is adequate perfusion. That means you can, and there is congestion. That means you can give a furosemide. No, you can give diuretic because size perfusion is normal. So you give the furosemide, IV furosemide 40 milligrams. If already on furosemide, you double the oral maintenance dose. Then you can repeat the furosemide boluses every 2 hours, and you double the dose every time if the patient does not respond, and going to a maximum of 400 milligrams. If you don't want to do that, you can give an infusion of furosemide. Then we are checking for if the blood pressure is high. If the blood pressure is high, is more than 120 by 80, then you can consider giving IV GTN as a vasodilator. Okay, and if you're giving IV GTN as a vasodilator, then the starting doses are given here. Okay, this I think you have to memorize. If the blood pressure, just remember, if the blood pressure is high, you can give IV GTN. Okay, if you can remember that itself, it's enough, I think, mainly. Unless I think some people will ask the doses, but try to remember the doses if you can. Okay, okay, then it's the ultimate phase. You give this, and you see that the diuretic and GTN you're giving, but still the patient saturation is low. Then what do you have to do? You have to take expert opinion, and you can start giving non-invasive positive pressure ventilation. So in heart failure, we give CPAP. So when you give CPAP, what happens is CPAP is giving you a positive pressure now. So when you give that positive pressure, it opens up all your alveoli, and whatever fluid is there within your alveoli, it pushes it out. It pushes it out. So that's why we give CPAP. Okay. So you can give CPAP if it is not working as the next line of this thing. If it is even bad and the patient is getting even worse, even with CPAP, then you go for invasive ventilation, where you put you intubate the patient and give ventilation. Okay. Then let's say the blood pressure is low. That means if blood pressure is low and the patient is not, there is poor perfusion, then we know that the patient is in a shock state, right? Or the patient is having poor perfusion, there's a shock state, there is a cardiogenic shock. At that point, you have to give inotropes. So the inotropes we give are usually, we can give noradrenaline. Noradrenaline can be given. Okay, noradrenaline is recommended now, but you can give IV dobutamine as well. So these are the doses which you don't need to know. Only if you know noradrenaline dose, because that is what you use mainly, it's enough, 0.05 micrograms per kilogram per minute. Okay. So just to recap on the management of this, you're checking the, first check the saturation. If the take a history examination, saturation is more than 94%, then you don't need to start oxygen. Saturation less than 94%, start oxygen. Then you have to make sure that the diagnosis is your pulmonary edema or heart failure. Then you're assessing the congestion, tissue perfusion. There is enough tissue perfusion, but there is features of congestion. That means the pressure is normal. Okay, normal pressure with congestion. Congestion means there is fluid overload. Start the patient on IV furosemide 40 milligrams, and then it does not get better. You can keep doubling the dose every 2 hours, and then you can start the patient on an infusion of furosemide. Then you also notice that the blood pressure is very high. So then you give IV GTN as a vasodilator to reduce the blood pressure. Memorize the doses. Then let's say you give GTN, patient is on diuretics, but patient is still, saturation is low. What are you going to do? You have to consult expert opinion and give non-invasive ventilation, give CPAP. CPAP is giving a positive pressure, opens the alveoli, pushes the fluid out. Okay. Now with CPAP, again, patient is not getting better. Now you're going to give invasive ventilation. You have to intubate the patient. Okay. So this is all when the you have started diuretic therapy. That means there is congestion. Now let's say the blood pressure is low, there's reduced perfusion. Okay. Then you have to give inotropes because you need to pick up the blood pressure. So for that, you give either IV noradrenaline or IV dobutamine. That's it. That's the management of acute heart failure. Understood that part?
Yeah, Macha. Yeah.
Yeah.
Okay. So that's all I have to share. Heart failure and ischemic heart disease. If there's anything you want to ask, you can ask. Or